Thank you for this invitation. Our title of our case scenario is Uncovering the Hidden Differential Diagnosis in Achalasia Workup. Today we'll talk about the case history and examination, investigation, etiology, and pathophysiology, differential diagnosis, and workup. Our case is a 35-year-old male patient born and live in Cairo. Patient came to our hospital with chief complaint of difficulty in swallowing for a few months and vomiting when taking solids and liquid with no halitosis. Patient has history of weight loss, about 15 kilograms in the last 2 months, associated with chest pain and regurgitation. Patient was completely normal. Later on, he had difficulty in swallowing solids, then gradually progressed to liquid as well. There is no history of odynophagia, no history of alcohol abuse or analgesic intake. There is no other systemic symptoms, past history, no patient not diabetic nor hypertensive, no history of blood transfusion nor drug allergy. Family history and surgical history is irrelevant. By examination, patient was fully conscious, oriented to time, person, and place. Patient was vitally stable, not feverish. Chest examination was free, abdomen is lax, no tenderness, no rigidity. Heart is normal sounds with no murmur. CNS, there is no abnormality detected. By investigations, patient labs were normal, and patient did first upper endoscopy that revealed mild antral gastritis. Biopsy were taken for histopathological examination. This is the upper endoscopy report, and this is the picture. Histopathological examination revealed antral mucosal endoscopic biopsy, H. pylori associated chronic active antral gastritis of moderate degree of infection, +2 activity +2, and chronic inflammation also with minimal gastric atrophy. There is no intestinal metaplasia, dysplasia, or malignancy. Unfortunately, patient symptom persisted, so the patient did X-ray barium swallow and another upper endoscopy for reassessment, and also manometry, higher resolution manometry were also done. The barium swallow showed achalasia of the esophagus with distal end tapering and consequent moderate dilatation of the thoracic esophagus, no intraluminal filling defects or diverticular outpouching, no evidence of Hayes hernia or gastroesophageal reflux seen. Upper endoscopy, the second upper endoscopy revealed achalasia of the cardia, successful balloon dilatation was done, and there is diffuse gastritis. High resolution manometry revealed type 2 achalasia, the finding 100% failed peristalsis with panesophageal pressurization with almost all swallows. The IRP was high, 39.2 millimeter mercury, high resting pressure of the lower esophageal sphincter, 60.7 millimeter mercury. Per-oral endoscopic myotomy was successfully done. First, there is non-satisfactory complete relaxation of the lower esophageal sphincter after complete myotomy, and the scope passed with difficulty. Another submucosal tunnel was created toward the cardia, and the myotomy was done across it. Hemostasis was ensured, and mucosal entry was closed using 5 endoclips for each tunnel, so we used 10 endoclips. This is a picture here. First we do mucosal injection, then mucosal incision, then scope opening and scope entry, then antegrade myotomy. Finally, we did closure of the incision. After the patient had done the per-oral endoscopic myotomy, the symptoms improved partially, but this patient was still complaining in difficulty in swallowing, so it was decided to perform the following investigation. CAP CT, CT chest, abdomen, and pelvis after oral and IV contrast that revealed right paraesophageal, partially cystic, partially solid lesion for EOS histopathological evaluation, multiple bilateral scattered pulmonary nodular density, mild hepatomegaly. PET-CT revealed metabolically active FDG and posterior mediastinal mass lesion, AFDG, avid nodal pulmonary and intramuscular lesions. So the patient went to surgeons that decided to take biopsy direct from this lesion, and the findings are compatible with spindle cell sclerosing rhabdomyosarcoma. And now the patient is in our oncology hospital and taking chemotherapy. Now we'll talk briefly in achalasia pathophysiology. Achalasia is uncommon disorder, result from progressive degeneration of the ganglion cell in the myenteric plexus in the esophageal wall, leading to decrease in nitric oxide and vasoactive intestinal peptide, and failure of relaxation of the lower esophageal sphincter accompanied by loss of peristalsis in the distal esophagus. Etiology of achalasia, two types of etiology, maybe primary idiopathic or secondary pseudoachalasia. Primary is most common. The exact cause is unknown, but the theories include viral infection, maybe after herpes simplex virus infection or measles infection, maybe after autoimmune diseases or genetic inheritance. Secondary achalasia, also called pseudoachalasia, may be infectious, like Chagas disease, malignancy, like esophageogastric junction tumor, paraneoplastic from extraintestinal malignancy, like lung cancer. Differential diagnosis in when the patient came complaining of the dysphagia, maybe dysphagia to the solid only, or solid and liquid. If it is solid only, we'll see if it's intermittent or persistent. If it's intermittent, it is indicated Chakasty ring. If it's persistent with heartburn, it may be a stricture. If persistent with no heart pain in old age patient, it may indicate carcinoma. If it's persistent with no heart pain in young age, it is eosinophilic esophagitis. If the patient came complaining of solid and liquid, and it is persistent with regurgitation, like in our case, it is a case of achalasia. If it is persistent with heart burn, it is scleroderma. If it is intermittent with chest pain, it is esophageal spasm. The workup we do in achalasia case of dysphagia, first we do barium swallow that shows a tight lower esophageal sphincter and dilated esophagus like bird peak appearance, upper endoscopy to rule out mechanical obstruction and malignancy, esophageal manometry, which is gold standard to evaluate both pressure of the lower esophageal sphincter and contractility of the esophageal body. Last, we do CT chest with contrast to avoid missing paraneoplastic from extraintestinal malignancy. My take-home message today is, first, persistent dysphagia to both solid and liquid may indicate the presence of achalasia. Achalasia may result from primary idiopathic degeneration or secondary causes known as pseudoachalasia, which frequently arise from malignancy or other infiltrative diseases. Pseudoachalasia can mimic or superimpose on achalasia. Careful evaluation is essential, especially endoscopy with biopsy and CT chest with contrast to avoid missing malignancy. Thank you very much.